Next is basically the different types of whenever we're talking, basically the different types of tracheoesophageal fistula. Sorry, tracheoesophageal fistula. Okay. Now it is basically four main types. Okay. First one is basically it is known as the first fill rider. It is known as the H type. It is known as the H type. Now, whenever we are saying that it is fistula, we basically say that it is an abnormal connection. Okay, abnormal connection. So in this, basically, we have uh, in this we call it as H type. Okay, we call it as H type because there is an abnormal connection. There is an abnormal connection between the sorry there is an abnormal connection. Okay. This is basically the bifurcation of the lungs, and it is associated with basically the esophagus and the oral pathway or oropharynx. Okay. Now next, this first one is the H type. Next one is, we call it as the lower end of the esophagus, the lower end of the esophagus. So the lower end of esophagus is blind. Lower end of esophagus is blind. Okay. So this part is basically lower end of esophagus is blind and upper end is connected to trachea. So sorry, lower end is lower end is blind and upper end is connected. Upper end is connected to trachea. Upper end is connected to trachea. This one is basically the second type. Okay, and this next is the upper part is basically connected to the trachea. This part is connected to the trachea. Next one is basically both the ends. Both ends are blind. Both ends, they are blind. Okay, that means this one is bifurcation. Okay. So there is no connection. There is no connection. Okay, you can see both of them, they are basically blind. Both of these, they are basically blind. Okay, next is basically the last one is, it is no the upper blind end and upper blind end and lower end and lower end. It is connected to trachea. Is connected to trachea. This one is the most common variety. Okay, so in this, when we are drawing it, this is a rough estimate. So in this upper blind end and lower end, this is connected to the trachea. It is connected to the trachea. This one is basically open. It's connected to the trachea. This one is the most common. This one is the most common type. Okay. Now, in this, when we are talking about if you are talking about management, okay. First, management of tracheoesophageal fistula. First and foremost is right thoracotomy. Right thoracotomy. Okay, and ligation of TOF or TEF, okay, and primary anastomosis. Primary anastomosis. Primary anastomosis of esophageal ends. Of esophageal ends. Because we want the food and the passage to become clear, we basically have to remove the blind pouches and all. Okay. Next is basically we do feeding gastrotomy. feeding gastrostomy and esophagostomy and eso- esophagostomy. Yeah. Esophagostomy. This is basically in type 3, or basically you can say C fistula. C fistula. Okay. And if there is a severe case, okay, then like we have to basically like if there is a difficult case, basically say a severe case in surgery as difficult case. Okay. And in difficult case, basically we are talking about that is we have a long atretic segment. We have a long atretic segment, colonic or long atretic segment. We basically require colonic or gastric transposition. Transposition. Now the next one is basically complications. Complications. Okay, basically complications, if it is associated, if it is contacting the trachea and all, it can basically result in pneumonia. It can result in reflux. It can result in dysphagia. And the last one is if we go for an anastomosis, after that it can basically lead to anastomotic leak. It can lead to anastomotic leak. Okay. This one is for tracheoesophageal fistula. Okay. Now in atresia, we're coming back to the topic of atresia. Atresia, we basically the diagnosis is confirmed. How do we confirm if there is an abnormal connection or if there is a blind pouch? Okay, that means we when NG tube is passed, nasogastric tube is passed, it does not go. Okay, it does not go further than the upper esophagus pouch. Does not go further than the upper esophageal pouch. Esophageal pouch. Okay, and how do we see that? We basically see on X-ray. We see it on X-ray, and if there is presence of abdominal gas, we can basically confirm esophageal atresia or tracheoesophageal fistula. Okay, and like basically post-operative complications of this, again it can be asked. Okay, so basically post-operative complications of this are it can lead to leak, anastomotic leak. We already studied that, like already I've written down anastomotic leak. Next one is it can lead to stricture. Stricture means basically tightening of this, basically narrowing, narrowing of whatever anastomosis of the anastomosis that we have done. Okay, and it can result in recurrent fistula formation. Recurrent fistula formation, and it can lead to gastroesophageal reflex. Gastroesophageal reflex. Okay. Basically the patient presents with very low birth weight. Okay, very low birth weight, and after repair and all, there is a good prognosis of patients with esophageal atresia. Just remember how we diagnose it and what are the treatment or what is the surgery that we have to do in this patient. The next topic, the next topic is basically cold abscess. Okay. Now, what is the definition of abscess? When we are basically when we are basically referring to abscess, we are referring it to a localized area of infection or a localized area of infection. Okay. Now, why do we call it as an abscess? Okay, because a cold abscess, because it is not accompanied. It is not accompanied by classic signs of inflammation. By classic signs of inflammation. Okay, what are the classic signs of inflammation? Rubor, dolor, calor, and basically pain. Okay, that is basically in normal terms. If you are writing it down, that is heat, redness, that is rubor, fever, that is basically calor, and pain, that is dolor. Okay, which are found in pyogenic abscess, which are found in pyogenic abscess. Okay, so this can be a sequence. Okay, this can be a sequence, or this can be a result. Cold abscess in India. Okay, in India, cold abscess can be a of result of caseation necrosis. Result of caseation necrosis. When we are talking about caseation necrosis of lymph nodes, caseation necrosis is basically most commonly seen in, it is basically cheese like appearance, and it is associated with TB. Okay, so it can be a sequence of TB. It can develop due to TB infection. Okay, the other causes of this can be actinomycosis, can be leprosy. Okay. Next is it can also be due to fungal infections. It can also be due to fungal infections. When we are talking about fungal infections, we are basically calling it as blastomycosis. Blastomycosis. Okay, these ones are the most common. The other causes. Okay, it is due to caseation necrosis of lymph nodes, which is occurring. Which usually caseation necrosis is associated with TB. Okay, so there is how the pathogenesis of this, of cold abscess. Okay, it is basically due to polymorphonuclear cells. Okay, polymorphonuclear cells, they are basically, they go into basically macrophages. They develop into macrophages and monocytes. The monocytes is basically which is present in the blood. Macrophages, when they enter the tissues, this basically lead to macrophages. They modify themselves. They are known as epithelioid cells. Okay, these epithelioid cells, they will basically progress into Langhans giant cells. We call it as Langhans giant cells, which progress into, so which basically leads to central caseation necrosis, and this basically leads to formation of cold abscess. Okay, now this can the sites where it can be present more commonly. Okay, like basically the composition of an abscess. Okay, composition of abscess, it can be due to, it basically composed of serum. It is composed of leukocytes. It is composed of caseous material. Star mark the caseous material, because that is what the examiner wants you to know. The next one is bone debris, and if it is caused by tuberculosis, then tubercle bacilli. Okay. Now the sites where it is seen. Okay. The sites where the cold abscess is seen, most commonly it is present at the and axilla. Neck and axilla. Okay. The other site where it can be seen is basically, it can be seen in loin region. It can be seen at the back region. It can be seen at the side of chest wall. At the side of chest wall. Okay, and it can also be due to tubercular infection. Due to tubercular infection of spine, that is known as pot spine, ribs, and posterior posterior mediastinal lymph nodes. posterior mediastinal lymph nodes. Okay, what are the clinical features? Clinical features of this. First and foremost is it does not have signs of inflammation, so it is a painless swelling. Painless swelling. Okay, and there can be there are symptoms of primary TB. There can be signs or some clinical features of primary TB. Okay, now the clinical features of this are basically mostly it is painless swelling. Okay, and it is due to tuberculosis, so there can be symptoms of primary TB. Okay. Now it can be present anywhere. Okay, differential diagnosis of this. Okay, it can be present anywhere. Like basically TB, if it is miliary TB, it goes throughout the bloodstream and all. It can be confined to the spine itself, that is known as TB spine or pod spine and all. So the patient usually presents with painless swelling. Okay, and a differential diagnosis of this is basically first and foremost is pyogenic abscess. Pyogenic means it is caused by Staph aureus. Next one is it can be differential diagnosis lipoma. Next is cyst. After that, soft tissue tumors or soft tumors or soft tumors. Okay. Now next is investigations. Investigations of this is first and foremost is lab tests. That is TB is Mantox. Okay, or we call it as tuberculin skin test. We basically tuberculin skin test. ESR is increased. Okay, and ELISA enzyme linked immunosorbent assay, and PCR assays. Okay, next is we can basically go for FNAC and biopsy to rule out any malignancy. Okay, and okay, biopsy is basically for confirmation. Biopsy is for confirmation. Okay, next is microbiology diagnosis. When we are talking about microbiology diagnosis, we are basically talking about how we Zeal Nielsen staining. Zeal Nielsen staining. Okay. This is for diagnosis of TB and all. Okay. Next is radiological examination. Radiological examination. When talking about radiological examination, first and foremost, we can go for plain X-ray. Plain X-ray. Plain X-ray. This can be like we have to diagnose it based on the location where the swelling is present or abscess is present. Okay. Next is it can be diagnosed by ultrasound, CT scan, MRI, spine, and bone scan. Okay, so the investigation is basically plain X-ray, ultrasound, CT scan, MRI scan, and basically bone scan. Okay, now treatment of this. Okay, treatment. Okay, first if we suspect that TB, then anti-tubercular drugs. Next is aspiration. Okay, and ultrasound guided. We are basically talking about ultrasound guided pigtail catheter drainage. Pigtail catheter drainage. Okay, this is ultrasound guided. Next is basically surgical management. Surgical management. Management is by open drainage. Okay, if aspiration failed to clear the abscess. Okay, next is we can use a normal drainage. we use a different type of incision that is known as non-dependent incision. Non-dependent incision. Okay, and later on, after we use a non-dependent incision, okay, we later on close the wound without without placing a drain. Without placing a drain. Now, why are we not like without? Why are we not placing a drain? We are basically to prevent sinus formation. To prevent sinus formation. Okay, and next one would be like if it occurs in the chest wall. If it occurs in the chest wall, that means cold abscess in the chest wall. It can basically require rib resection. It can sternum resection. Sternum resection with abscess excision. With abscess excision. Okay, that one is a main one for when we are talking about cold abscess. First and foremost, we have to write down the diagnose, like what does cold abscess basically mean. Okay, then we can basically continue with. Okay, so next one is basically TPN complications. That is total parenteral nutrition. Okay, we basically PN is parenteral nutrition. Parenteral nutrition. Okay, now complications of this. Okay, complications of this is first and foremost complications. Why is total parenteral nutrition given? This can be considered when like uh, when enteral nutrition is not possible. When enteral nutrition is not possible, then we go for total parenteral nutrition. Okay, and like the main thing that you have to remember is that we have basically central venous catheter. Okay, and the basically the we call it as venous access. Okay, this should only be, it should only be only for PN, that is total parenteral nutrition, and it should not be used, not to be used for drugs, for administration of drugs or other fluid, for administration of drugs or fluids. We basically give only parenteral nutrition. Okay, and it should always be under aseptic conditions and all. Okay, now coming back to the complications, first one is basically technical complications. Okay, because central vein and all, so technical complications. When we are talking about technical complications, okay, we are basically injury when we go for central vein catheter access and all. Injury to the subclavian. It can cause injury to the subclavian. It can cause injury to the carotid artery, okay, and it can result in injury to the brachial plexus. It can result in hemo or pneumothorax. This is while performing the inserting the catheter into the central veins. Okay. Next is it can result in like central line sepsis. We basically call it as central line. Central line. The central line is the procedure by which we gain access into the central veins and all. Okay, this one is central line sepsis. This one is the most dangerous, life-threatening, but it is a preventable complication. Okay, next is it can result in gut mucosal atrophy. Gut mucosal atrophy. Basically, when you're talking about gut mucosal atrophy, okay, why? Because what happens is when patients are put on total parenteral nutrition, they basically develop atrophy of the intestinal mucosa. So if there is atrophy of intestinal mucosa, it can basically result in loss of barrier function. And when it results in loss of barrier function, it basically results in, it becomes, barrier function is lost, that means it becomes permeable to bacteria. It can become permeable to bacteria. Okay, and this basically can lead to sepsis. This basically lead to sepsis. Okay, so like this is not seen in patients who are given on partial parenteral nutrition, or who basically we go for enteral nutrition and all. The major complication of total parenteral nutrition is cholestasis. This is basically a long-term complication. A long-term complication. The patients present with jaundice. The patient can present with signs of jaundice. Can present with patient signs of or basically gallstones. Okay, and these, they resolve on, we when we resolve on switching to oral or enteric nutrition. Okay, and last complication of this is basically fluid, electrolyte, and acid base base imbalances full fluid, electrolyte, and acid base imbalances. Okay, so these are the complications of total parenteral nutrition. Next question is basically laryngeal mask airway. Okay, laryngeal mask airway. Okay, when we are studying about laryngeal mask airway, this is basically a supraglottic airway. This is a supraglottic airway. Okay, now it basically has a tube. Okay, this one is the tube. It basically has a tube, or we can also call it as a shaft. Okay, or a shaft. Okay, and it has a width, a standard. Basically, when you're talking about standard, all of the laryngeal mask airways, they basically have a standard 15 millimeter connector. 15 millimeter connector. Okay, at proximal end. At proximal end. This, why do we have this? To end to connect to the anesthetic circuit. Okay. Whenever we're talking about anesthetic circuit, it can be basically ventilator and all of it. Okay, and the patient's end has an oval shaped inflatable cup. Okay, has an oval shaped inflatable cup. This is inflatable cup. Okay, which when inserted rests just above the larynx. Okay, sorry, not that one. Okay, it is basically, it results in like oval shaped inflatable cup. Okay, which when inserted rests just above the, which when inserted rests just above the larynx, just above the larynx, and creates airtight seal. Creates airtight seal. Okay, so laryngeal mask, it has a inflatable cuff which when inserted just above the larynx and creates an airtight seal. Now uses of this, first and foremost, is to administer anesthesia. Administer anesthesia. Next is, it can be used to maintain airways. to maintain airway. It can be used to maintain airway in patients with difficult airway. In patients with difficult airway. Basically, when talking about difficult airway, that means where ET, endotracheal intubation, is not possible. Okay, and it can also be used as a conduit for passage of ET tube, that is endotracheal tube. Okay, either blindly or with the use of fiber optic bronchoscope. These one are the uses of laryngeal mask airway.